Hello, my friends. Dr. Said Kazmi here once again, and today we are going to talk about Helicobacter pylori. Now, Helicobacter pylori is an infection of the stomach, and it's a bacteria which causes chronic gastritis. It can cause peptic ulcer disease. It's quite common in the adults, but today we are going to take a view of this infection in children. Now, to begin with, the Helicobacter pylori is considered to be a gram-negative organism. So it's a gram-negative microaerophilic bacteria. It means it requires a little bit of oxygen to thrive in. And it primarily infects the lining of the stomach, causing chronic gastritis. It can cause peptic ulcer disease, leading to peptic ulceration. And it has also been associated with the gastric cancers and some of the other gastrointestinal conditions like Malt syndrome. Now, this was first described in 1983 by Barry Marshall and Robin Warren. And after that, they started researching because that was the first time that they discovered this bacteria as a cause of peptic ulcer disease. And since then, there has been a lot of research on this bacteria and the conditions caused by this. Now, not only in the adults, but research has found out that the infection is also quite common in children, though later on we would see that most of these infections are asymptomatic. So in this particular lecture, we are going to explore the epidemiology, the transmission, the clinical presentation, some of the diagnostic methods used to diagnose this infection, and the treatment modalities which are present in this point in time. So to begin with, the first thing is the epidemiology of Helicobacter pylori infection. Now, global prevalence, as far as that is concerned, they say that around 50% of the total global population is affected by that. That means every other person is affected by that. So if you are watching this video, so if we are two, one of us is infected, and I know I'm not infected because I had my endoscopies for my reflux esophagitis a couple of years ago, and I was tested negative for Helicobacter pylori. So you must be infected by H.Pylori infection. Sorry, I'm just kidding. Nothing to get worried about that, but as I said, that the prevalence is quite high, and this prevalence actually varies. It's not like sort of that this would be the prevalence in each and every country. Some of the rich income countries have got low prevalence, and the low income countries have got high prevalence. So it has to do something with the socio-economic condition as well. So they have found out that it's been reported to the prevalence is quite high in certain countries like Nigeria, Siberia, South Africa, and some of the Latin American countries like Nicaragua and Colombia, where the prevalence is very high, like 83 to 89%. While some of the countries like Yemen, Indonesia, Belgium, Ghana, and Sweden has got low prevalence, that where it ranges between like 9% and 15%. Now, coming down to the pediatric prevalence, because basically we would be focusing this lecture on from the pediatric perspective. So in South America, 52% of the children and like adolescents or teenagers are thought to be infected with H. pylori. Most of these infections in children are asymptomatic, and that's a good thing because it doesn't lead to any problems. Moving on to the transmission and risk factors. The most common transmission is from person to person. So primarily from one person to another person, from like, let's say, from child to child, mother to child, dad to child. And the most predominant routes are oral to oral and orofecal transmission. They are considered to be the most important modes of spread of this bacteria. They also think that contaminated water might have to play a role, because in most of the low-income countries where we think that the water channels are mostly contaminated, the prevalence is quite high. And they also think that to some extent dietary factors may also be at play, like for example contaminated meat, contaminated milk, vegetables, things like that. They might be responsible for causing the transmission. Moving on to the clinical manifestations or clinical presentation. Now, in children, and it's important, in children, majority of the infections are asymptomatic. And the research says that 85% of the H. pylori infections are asymptomatic. It means the bacteria is there, it has infected the lining of the stomach, but there are no symptoms. And they say that the common age around which these children they get this infection is around 10 years of age, plus minus, plus 2-3 years. Now, in case if any symptoms occur, they are non-specific gastrointestinal symptoms, most common being abdominal pain. So upper abdominal pain, which we call as epigastric pain, is the most common. But epigastric pain can be caused by so many other things as well. So it's a very non-specific sign. So abdominal pain in the form of epigastric pain, sometimes they can feel nausea, They can rarely have digestive bleeding or what you call upper GI bleed as well, especially if they've got erosive gastritis or if they've got peptic ulcer disease. But that's like quite a rarity. It's not that much common. And some kids might have a bit of like vomiting as well. But as I said, these are very non-specific symptoms, and not in every case you can make a sort of a relationship that there would be a sort of a Helicobacter pylori, underlying Helicobacter pylori. Though, as we say, if the infection is so high, it could make a difference. But nevertheless, as we said, like, this is quite tricky. I mean, in most of the cases, H. pylori infection is not thought to be the reason for the symptomatology, even if it is occurring in a child who has got H. pylori. Anyhow, that's quite a tricky thing. So external intestinal manifestations can also occur. They are rare, but some of the important ones that we consider are associated with H. pylori infection are chronic thrombocytopenia purpura. So chronic idiopathic thrombocytopenia purpura is thought to be associated with chronic Helicobacter pylori infections. And another one thing which is usually associated with the Helicobacter pylori infection as a complication is intractable iron deficiency anemia. If somebody has having intractable iron deficiency anemia, we are not able to find a cause. One of the reasons could be Helicobacter pylori infections. And strangely and interestingly, some things are thought to this H. pylori bacteria is thought to be protective against something. We don't know the mechanism, but they say that H. pylori infection has got a protective effect against bronchial asthma and inflammatory bowel disease. So like, if they've got this infection, they've got low chances of having asthma and inflammatory bowel disease. We don't know the reasons for that, why it is happening, but it does happen. It's quite strange. It might be like sort of a spurious association, but somehow we have found that there's something exists between these two. Now, coming down to the diagnostic approaches for Helicobacter pylori. So how do we diagnose that? Now, for diagnosis, we have got two types of methods: invasive methods and non-invasive methods. Now, keep it in mind that for making a primary diagnosis, it's very important that invasive methods are used. And invasive methods are obviously your upper gastrointestinal endoscopy, in which an endoscope is passed with a camera, and biopsies have to be taken. Because this is a sort of a bacteria, you can't see it through the eye of the camera, so you have to take biopsies. And they say at least 6 biopsies have to be taken from different areas. Now, in children, the most common area in the stomach where this bacteria enters is the pyloric antrum. So nodular gastritis, if you see there is a nodular gastritis, that probably gives you an idea that there might be an underlying H. pylori infection. So in that particular case, biopsies have to be taken. So once a biopsy have to be taken, they are like examined under the microscope to see if there are changes associated with H. pylori. So one is that. Number two is you can use samples to do culture as well, which is the most sensitive but not easily done. And another one thing which is quite sort of quickly done in on the samples of the biopsy is your rapid urease test, because this bacteria produces an enzyme urease which like splits urea into ammonia and carbon dioxide. So that particular property of the bacteria can be used to diagnose this. So once you have taken biopsies, you can do microscopy examination. You can do a culture on that. So 1 microscopy, 2 culture, number 3 rapid urease test. So this is done when you pass an endoscope. So this is an invasive method, and this is always used for making the primary diagnosis. This is very, very, very important. And I will tell you that not every child, because infection is so common, you do not do endoscopies in all these children. You would only do endoscopies if you think that there is a definitive infection causing some problems like peptic ulcer disease. I will come to that in a moment. But as I said, there are certain, the European Society for Pediatric Gastroenterology and the North American Society for Pediatric Gastroenterology, they've got like very clear-cut guidelines who need to be scoped. Coming down to non-invasive method. Non-invasive methods are your urea breath test and the stool antigen test. Now, this in children are not done as a part of the primary diagnosis. We only do these tests after the primary diagnosis has been made based on the endoscopy, and then you have given them treatment, and now you want to see the response to treatment. So whether the treatment has eradicated or cured the infection or not. So 4 weeks after starting the treatment, the children, they undergo stool antigen test, and if the stool antigen test is positive, then you also have to do the urea breath test. So these are like non-invasive tests. In stool antigen, you just have to take a stool sample, and in urea breath test, this is usually done in older children who are able to give you a breath sample, and then in that particular case you can see if that comes out positive or not. So non-invasive methods are used for what? For looking response to treatment. So invasive methods for primary diagnosis, non-invasive methods like stool antigen and urea breath test for what? Seeing response to the treatment. Now, the sensitivity and specificity of these tests are actually a gray area. Certain tests have got like good sensitivity and poor specificity. Some have got like poor sensitivity and good specificity. So again, the clinician has to decide based on the statistical probabilities of seeing whether this child has got more chance of infection, whether he's got more chance of having something else. So, in the light of those things, the gastroenterologist or the pediatrician would be making a decision from which method to go for. But by and large, invasive methods for primary diagnosis, non-invasive methods for looking at the response to treatment. I hope this is clear to you guys. Now, moving on, treatment strategies. Now, as I told you, that treatment would only be offered if you find H. pylori infection based on invasive methods. You don't like simply if you suspect that there is H. pylori infection and you treat it like, with the triple drug regimen. That is never recommended. The EPAGHAN and NASPGHAN guidelines, they clearly say that it is only recommended for children who undergo endoscopies, who are actually tested positive for H. pylori infection, or those who have got complications. And what are those complications? Peptic ulcer disease, refractory iron deficiency anemia. If somebody's got iron deficiency anemia, you don't know the reason why it is happening, you give them iron, it's not like sort of curing the problem. Or if somebody has got a chronic thrombocytopenia purpura associated with H. pylori infection. So these are the sort of the scenarios, then in that particular case you have to treat them. And I will come in a moment like what is the triple regimen recommended for H. pylori infection treatment. Now, it is also important that you consider the antibiotic resistance. Like H. pylori is becoming resistance to either clarithromycin, which is one of the main medications used today, or metronidazole. So clarithromycin and metro, they both are used to treat H. pylori infection. But recently we are seeing that the bacteria is becoming more and more resistant to these antibiotics, and that is causing a treatment problem globally. So some of the treatments, there are different combinations that are used for that, again depending on the physician discretion, and there are guidelines for that. But usually these are known as triple regimens. So triple regimen, one of them is definitely a proton pump inhibitor. So you use a proton pump inhibitor like omeprazole or lansoprazole or esomeprazole, which is like a sort of an integral component of the triple therapy. The second one is usually amoxicillin, okay, and it could be clarithromycin, and sometimes we use metronidazole. So amoxicillin and metronidazole or clarithromycin. So you have to use one of them, either clarithromycin or metronidazole for the treatment. And sometimes we might have to add a fourth drug as well, which is known as a quadruple therapy, in which usually the fourth drug is a bismuth-based medication. So to show you the what you call the treatment modalities, this is from the EPAGHAN and NASPGHAN guidelines. They say where the your local data suggests that the H. pylori is susceptible both to clarithromycin and metronidazole, then you have to give them triple therapy for 14 days, in which one of the drug would be omeprazole, where you can give them 20 to 40 milligram twice daily depending on the age, and the second drug would be amoxicillin, which is usually given in the dose of 500 to 1000 milligram, and that has to be given BD again twice daily. And the third one is clarithromycin, where again the dose varies from 250 to 500 milligram twice daily. So if you see, all these medications are twice daily, whether it's omeprazole, amoxicillin, or clarithromycin, twice daily. So where there is susceptibility, you will use omeprazole plus amoxicillin plus clarithromycin. Where clarithromycin is susceptible and metronidazole is resistant, again, it is better that you use the same therapy. So you will be using omeprazole, amoxicillin, and clarithromycin. The dosages are the same and the frequency is the same, BD. Where there is clarithromycin resistance but metronidazole is susceptible, in that case you would just switch clarithromycin with metronidazole. So the rest of the medication would be the same: omeprazole or lansoprazole or esomeprazole twice daily, or amoxicillin twice daily, but instead of clarithromycin you switch to metronidazole, and the dose is usually 250 to 500 milligram twice daily. Where you don't know, where the research doesn't tell you what is the sort of a susceptibility of the organism, or you think that there might be double resistance, like where the organism is both resistant to clarithromycin and metronidazole, then you have to give them these medications in high doses. So omeprazole would remain in the same dose, 20 to 40 milligram twice daily, but amoxicillin is increased. So instead of using 500 to 1000 milligram twice daily, you would up the dose to 750 to 100 to 1.5 gram twice daily. And metronidazole is used the same. So in that particular case, if it is the what you call the susceptibility is not known, it's better that you use metronidazole instead of clarithromycin. And some of the alternative treatment options are that if you think that the resistance would be a big problem, then you can add bismuth-based medication. So bismuth salicylate can be added, and you can continue the treatment for 14 days. So 14 days of treatment is given, in all these, sort of these triple or quadruple regimens. And after that, you will check them again to see if the organism has been eradicated. But you don't need to do the endoscopy again. Probably you'll go with non-invasive tests like the urea breath test and the stool antigen test. Moving on to some of the factors that influence your treatment outcomes. So as I told you earlier, not everybody would be having the same outcome. So it depends on the antibiotic resistance as well. So where antibiotic resistance is low, you'll be having better, sort of treatment outcomes. Where the antibiotic resistance is high, probably if you're treating 100 children, not everybody would get sort of a favorable treatment outcomes, and many would still be persisting with the infection. It also depends, because of 14 days of treatment, you have to ensure that there is a high degree of patient compliance to the treatment, because some kids might not be able to tolerate these medications very well because of the palatability issues, or maybe associated nausea and some of the side effects which are usually associated with these antibiotics. So it's very important that treatment adherence is sort of adhered to. So those areas where compliance is high, more chances of what you call successful treatment. Where the compliance is low, vice versa. Similarly, there has been a debate about the use of probiotics as a part of adjuvant treatment for H.Pylori infections, and the data has been sort of I would call it ambivalent sort of results, because in certain studies it has shown that it improves the profile of the side effects, so less side effects when you give them probiotics, and it enhances eradication rate. But the other studies, it has not shown any beneficial effect. So we don't know, but again, depending on the local data, probiotic supplementation can be used as an adjuvant treatment just to decrease the side effect profile. And again, treatment duration matters a lot. 14 days is the standard treatment time to sort of eradicate this infection from your stomach. Some people, they do get recurrence and reinfections. So the thing is that while they might be sort of if you do the urea breath test and stool antigen test, you might see that they have been cleared, and then again they redevelop the infection. So the thing is that there are two terms used here. One is recrudescence and one is reinfection. So recrudescence means where the infection has subsided, but the bacteria has not been totally eradicated. It's still lying there dormant. As soon as the treatment is stopped, those bacteria again, they multiply again and they cause a heavy infection. So that is the recrudescence, where the same strain actually becomes active again, and it causes the same infection within the first 3 months to 1 year of eradication treatment. That is recrudescence. Reinfection mean where it has been cured, but you get infection from another strain of the H. pylori. And this is usually less common as compared to the recrudescence, but still it can happen. And it's very important that once you have treated or successfully eradicated H. pylori, you have to maintain negativity for at least 1 year. It's very important that for 1 year the child should be negative of this H. pylori in the form of a negative urea breath test and negative stool antigens, which is taken as a marker for successful treatment. Because in between, if they become positive again, it simply means that the treatment has failed. So some of the further future considerations and some of the research needs as far in the field of H. pylori infection are: number one, that we need to further work up of individualized treatment approaches. At the moment, we have got a sort of a blanket approach for everyone in the form of triple regimen, and the side effect profiles of these antibiotics in high doses is there. So usually compliance becomes an issue. So it's important that the further research is done to see how much the individualized treatment approaches they are successful. Number two is that we also have to look at the emerging therapies. Like it's been a long time that the standard treatment in the form of omeprazole or amoxicillin, clarithromycin, or metronidazole has been going on. With there have been some research going around probiotics as well, but we need to find out if there are further antibiotics with a lesser side effect profiles that are effective against H. pylori. And because most of the research has focused on the adults, it's also a high time that research is focused on the pediatric age group to find out what would be the best treatment modalities, and if there are any further diagnostic approaches which can be utilized in children to diagnose this well in time, and also to measure response to the treatment. So this was all about H. pylori infection in children. Most of the material used in this presentation comes from the EPAGHAN and NASPGHAN guidelines, which are the European and the North American Society for Pediatric Gastroenterology, and they are used all over the world. If you've got any further questions, put it down in the comment section below, or you can if you've got something to share, you can put it down in the comment section as well. And that's it. So I'm signing off. Have a good day. Bye bye.